And welcome everyone to the SHSMD webinar, Medical Staff Development Planning in 2021. This webinar is being recorded and is broadcast in listen-only mode. There is a question in the chat, so please weigh in there in the bottom right-hand side of your screen and use this chat to ask questions throughout the presentation today. We have a lot of time at the end for Q&A. At this time, it's my pleasure to introduce today's presenter. Travis Ansel is Managing Partner for HSG Advisors, a national healthcare consultancy focused on working with healthcare systems in the area of provider strategy, operations, leadership, compensation, and growth. And SHSMD would like to extend a sincere thank you to HSG Advisors for sponsoring today's event. At this time, Travis, the floor is yours.
All right, perfect. Thank you, Stephanie. Hello, everyone. Good afternoon and welcome to Medical Staff Development Planning in 2021. As Stephanie said, my name is Travis Ansel. I'm Managing Partner of HSG Advisors, management consultancy based out of Louisville, Kentucky, that works nationally with health systems in the area of provider strategy, operations, and leadership. Today, we'll be kind of walking through our observations on what we're seeing out of medical staff development planning efforts in 2021 and kind of giving our observations on what we find effective and what we find maybe to be less effective. If anyone's looking for a handout of today's presentation, that's available when we get to the end of the survey. Please enter your information in the post-webinar survey, and we'll be happy to send you a copy of the handouts along with a copy of our most recent white paper, which expands upon today's content, appropriately titled Health System Medical Staff Development Planning. So as I said, today we'll be giving thoughts on basically what we see as the core components of a medical staff development plan in 2021, how we've seen that process evolve. And then we'll be taking your questions and answers. I'll try to leave 10 to 15 minutes at the end of today's presentation for that effort. So as we jump into this, Stephanie, we wanted to open up another poll.
On the right-hand side of your screen, you can select your responses.
Thank you. And I'll kind of talk through an overview as everybody has a chance to click through that. So in 2021, I think if there's a main purpose of today's presentation, I think what we've seen over the last decade, and especially in the last 3 to 5 years, as access has really come to the forefront of most health system strategic plans, we're really seeing a disconnect in health system strategy and our strategy towards access, and what our medical staff development, community needs assessment, provider workforce development plans, how those two things are connected in order to provide access. And our definition of access being what's on the screen here, the right provider in the right location at the right time with the right provider capability. We really see the medical staff development plan as being the opportunity to really tie together what our health system strategy calls for us to do and being able to, in terms of being able to serve our market, and how we proactively develop a plan for building a provider workforce that can fulfill those needs. However, what we see in a lot of organizations is that this kind of planning effort is still very disconnected. Health system strategic planning kind of happens in its own bucket. Recruitment planning still kind of happens in its own sphere with its own, kind of combination of different strategic plans, executive level thoughts, service line strategies. We see a lot of recruitment plans kind of being amalgamations of different strategies rather than a strategy that is comprehensively developed and tied to the organization's strategic plan. And we really advocate for the medical staff development plan in 2021 to be that process that kind of brings everything together and says proactively what provider workforce allows us to best execute our strategy. We see a lot of organizations focusing on just community needs studies, and that might look like something you see on the left here, where we do an inventory of all providers, contrast them against some of the models that maybe the Stark regulations kind of require us to use to build Stark 3 market analyses and generate basically a community need study. And they usually have really high demand for primary care, really high demand for psychiatry. If you're in a competitive market, most medical and surgical specialties are oversupplied, and that type of process is really helpful in, of course, dealing with compliance related issues, because we, of course, if we're supporting independent practices, we do have to be mindful of Stark. And it's a great way to just understand kind of the supply dynamics of a market, but it's not really useful for a strategic purpose. And we really have to think about access not as a community need, but as a strategy for our health system. And so it requires us to really broaden the process beyond just looking at community need numbers. And so while it may be useful for thinking about, again, compliance strategy, and it may even be a component of access, again, supply and demand for specialties within a market, it really doesn't take into account the competitive concerns we have in a market. It doesn't fully consider our organization strategy. So if we want to grow certain service lines that are very competitive in the market, we really might not care about community need. You know, it doesn't fully consider community need, doesn't really fully consider the market the health system serves, because again, if we're focusing on just a select set of zip codes when we're doing a community needs study, there's always the opportunity to, especially for some of our core service lines, to draw patients from a broader market. So we're never going to have that look just right from a community need perspective. And I think most importantly, it doesn't acknowledge that physician employment has really changed the landscape for how we need to think about provider workforce development, because community need studies really started at least due to Stark in the early 2000s. That methodology we still see being utilized a lot here in 2021. With where employment's gone over the last 15 to 20 years, we have, as health systems, have so much more control over our aggregation and deployment of provider resources, since employment's such a dominant model, that we really can consider, not just whether the community's needs are met from a specialty perspective, but whether our organization's needs are met. And we really think that's what medical staff development planning has to address today. So with that, let's go ahead and start talking about what we think are some of the critical components of effective medical staff development plans. Here on slide 11, we kind of lay out our overall medical staff development plan framework, which talks about breaking it down into the 4 boxes. What organizational strategies must we consider as we build a medical staff development plan? So not only looking at the health system strategy, which I've talked about, as well as our service line strategies, but really proactively thinking about our strategies for ambulatory and outpatient growth, footprint growth, service growth, and as well as thinking about, how quickly is our market moving towards value, and what are the implications for the composition of our medical staff and closely aligned and employed providers, and how do we consider how that might change as we switch from being fully fee for service or mostly fee for service to having some components of fee for value in our market. And then we also need to think about competitor strategy and activity, and where do we want to be proactive rather than reactive, thinking about the implications of where our competitors might be going. In terms of aggregating, what data points should be aggregated? So again, we're advocating not just for looking at provider supply and demand, but layering in other data points that might tell a more complete picture as we think about bringing our strategies together. And this is what we'll focus on throughout the presentation today. But in addition to provider supply and alignment, as well as demand, we advocate that looking at how patients utilize the care continuum in a market, especially on the outpatient and ambulatory side, provides a lot of insight to medical staff development planning, as well as just organizationally. But especially for the medical staff development plan, being able to understand how patients utilize outpatient ambulatory services, where our gaps are, where patients are going around our network, where patients are leaving our network, is an absolutely critical data point to be able to layer into these other data points to develop a strategic medical staff development plan. We also think it's one of the things we see left out from a lot of health systems is kind of bringing together the viewpoints of the employed network from a existing capacity and access perspective with kind of the strategic recruitment need, and looking for opportunities to fill capacity before we add to our existing supply. Provider workforce age dynamics, succession planning is always a hard topic to talk about, because it's one of those things that's always very out of our control as a health system. But one of those things that's absolutely critical we have our arms around in the medical staff development planning process, because most organizations are starting to see 25, 30, 35% of their medical staff above age 60 in the next 3 years, which is a scary place to be. And so having our arms around that and thinking about the implications of it are incredibly critical. And then finally, grabbing provider opinion through the process. And we'll talk just a little bit about that. But not only relying on quantitative data, but also what insights can be gleaned from talking to our existing providers, especially helpful from a compliance perspective when other data points might not suggest we need to recruit a certain provider, but the medical staff has a different opinion, which can be layered into some supporting analyses. When all those data points are aggregated and we put them in the context of the strategy, we advocate for medical staff development plans to be comprehensive in their involvement. So as we're developing a plan, these cohorts of leaders within a health system need to be involved. It shouldn't be done as a disconnected process. It should be done as an integrated process. And then finally, what the plan should consider, not only our growth priorities, but our succession needs, our future strategic needs, the dynamics of provider mix, and then finally, not just who do we recruit, but what is our theory, at least, about where we're placing these providers in order to have some form of proactive plan. So we're gonna talk about all these elements today, but really focus here on the data points that need to be aggregated, because we think that's probably the biggest gap in what we're seeing between effective medical staff development plans and maybe the way some health systems are approaching them. So in terms of the there's 7 elements we want to talk through today that we think make for effective medical staff development planning from a data perspective. One is thinking about how you address your market definitions, and this is usually an opportunity for most health systems. One, to maybe think about their market in a different way. Usually think about it a little more broadly than they maybe historically have, given just kind of the requirement that health systems grow in today's environment. So thinking about maybe we broaden our market, but also thinking about our market at a more granular level. So while we may recommend thinking about a bigger market, taking the definitions of how we break up a market and make healthcare and think about healthcare a little more locally, incredibly important. 2, understanding the utilization of the care continuum by patients within the market. So understanding ambulatory and outpatient utilization and understanding gaps in that. Doing the community needs study, incredibly important. Looking at succession planning dynamics, looking at capacity, defining the ideal mix of physicians and advanced practice professionals, and then leveraging stakeholder observations and insights. So let's start with tailoring market definitions. Our observation is a lot of organizations are still focused on their historic primary, secondary, tertiary definitions. Those are maybe sometimes fine from an overall strategic plan standpoint. Maybe that's fine for a lot of our core service areas more service lines that might draw from a more tertiary perspective. But as our observation is, as healthcare becomes more local, and especially as competition becomes more fierce, the need to bring resources to a market that we want to compete in becomes greater. And that's not just from a primary care perspective, but from a specialty care perspective as well. So through this process, we would advocate for creating more granular market clusters to think about provider strategy that can inform recruitment needs at the local level. So what might that look like? Here's a sample market where we've created sub-market definitions, taking a large market, breaking it down into markets that might have some commonality. We generally recommend focusing on 5 things: common routes of travel. So how do we travel throughout a market? What's our historic penetration from a market share perspective in that market? How much of the velocity are we trying to redirect towards us versus how much have we historically captured? Where do we have demographically similar groups that might require or that might allow for grouping them together and creating a strategy for them? Where do we have common competitive threats? And then what's our strategic priority for each of these areas? And this allows us to create a little more targeted thoughts as we're building the medical staff development plan about what we need. We, at least here internally, think about this in terms of a framework for submarkets that's basically just based around 4 high-level strategies, and any organization can do this on their own, doesn't require our help. But when we're thinking about submarkets, as we look at each of these individual colors here, it's helpful to think about them just to develop a high-level strategy of what is our goal in serving that market. And if we've tailored the definition of that market right, then developing a single strategy for that market, at least at a high level, should give us the right direction as we're building the medical staff development plan. And so when we're creating these market definitions, we usually pull together 5 data points, which again, every organization can do for themselves. But really thinking about, one, what's our current employed primary care penetration in the market? Or what just overall is our primary care penetration in the market? I guess it doesn't have to be employed, but in most markets it really is. 2, what's our historic market share from that area? How much of it do we currently capture? And what dynamics, if any, are we trying to change? 3, what does our competitor penetration look like? 4, what type of access do we have to our specialty care and our acute care? Really with the thought, if we're trying to serve that market, what are we asking the patients in that market to do in order to get to our specialty and acute care services? And then 5, what do the demographics of the market look like? Just as with most markets, commercial and Medicare Advantage are generally more attractive, but that may or may not be true for your market individually. Aggregating those 5 data points, we would say generally will take you into one of 4 strategies. One, we want a market that we want to reinforce and defend. So we have a dominant position. We want to make sure we continue to have a dominant position. We want to make sure the patients who we're serving in that market's needs are met, and they don't need to leave our market that we're currently in great position in, which has a couple sub strategies there. 2, markets that are strategic growth opportunities. So if we're seeing an area where we haven't historically had a lot of penetration, but there's not a lot of competitor penetration, these tend to be growing markets that, suburban markets, those markets where people have historically aggregated faster than healthcare services. Those are markets where, there's something to be gained by investment. And if there's reasonable access to our resources and the demographics of that growth are favorable, that's what we consider to be a strategic growth opportunity market. Some markets within a market we might consider to be highly competitive, where we aren't there, competitors are, but it's a market we might like to play in, and that has a different strategy. The most pertinent point of which is we see a lot of organizations maybe dabble in investing in competitive markets. Let's put practice plus immediate care plus diagnostics in there. Let's build a little ambulatory center and put it in a market where we have 8% market share, and let's see if we can get a foothold. Working across organizations over time, we tend to see that being a pretty poor strategy, and usually something that one executive does, and then 5 years later another executive undoes. We generally favor, if we're going to move into a market, we do so with a proactive plan and kind of a bolus of resources where we enter in a significant and rapid form. And then a fourth categorization might be, there's some markets that we aren't going to actively place resources in, but still want to draw from. And in those cases, we're not there a lot, no one else is there a lot, and sometimes it's for a reason, geographically hard to access, or demographics that don't really warrant increased investment from the health system from a financial sustainability standpoint. So taking your market, thinking about how broad does it need to be, 2, subdividing it into manageable chunks, and then applying this type of framework really gives us a feel for where do we want to invest resources. And as we think about the other data points we're going to talk about, kind of gives us the context for, okay, if we need to invest in a market, where are we investing, and what are we doing in that market? The second thing we wanted to talk about is the utilization of the care continuum by patients of the market. So this is something that's a little newer. We've seen organizations start focusing on in the last 5 to 7 years or so as more data has become available in this space. We see a lot of organizations focusing on basically inpatient only market share, and we think that creates a blind spot in outpatient and ambulatory, which in most markets is 50 to 80% of revenue, depending on if you're a urban hospital or maybe a more rural hospital. But having your arms around what's going on in the outpatient and ambulatory space we think is critical to consider when we're talking about medical staff development planning. Understanding overall patient share of care, so how much of the total dollar are we capturing, not just the inpatient, but the total patient spend, gives us an idea of what are we not capturing, and are there conclusions to draw about why. And we've made the observation that I think overall health system strategies should encompass as an objective increased capture of the total patient dollar. But especially when we're thinking about medical staff development planning and we're looking at this on a service line level, how do we increase that by 1%, 3%, 5%? How do we incrementally increase our capture over time? So what might that look like? So what we have here is an organization, sample organization that is capturing on average about 35 cents of the total patient dollar. That's neat to know, doesn't really tell us anything other than our kind of overall position in the market. That varies a little bit between commercial and governmental payers, but again, not very interesting from a medical staff development planning perspective. But what is interesting is when you start breaking that down by service line and looking for variation in service line, because with our current competitive positioning in any market, we would reasonably theorize, if we're making the investments we want to make, that most of our service lines are all reasonably profitable. And of course, there's going to be variation. But we would theorize that a lot of organizations should have a relatively consistent patient share of care across service lines. And so when we're seeing divergence in consistency, as we might hear between, say, for this organization with a very small capture of oncology business compared to what appears to be their consistent patient share of care of 45 to 50% of the market. It might point out that we might have gaps in our, even ability to serve non-Medicare commercial patients. It might point out that our GI patient capture is pretty low. All of these are great data points to maybe base a strategy around. How do we grow that? But it doesn't necessarily tell us on its own that we need to invest incrementally in oncology or GI, but it's an important data point, just like everything else we're talking about, to bring together when we're kind of comprehensively developing a plan and asking the question, why are we deficient in some of these areas rather than others? And if we start aggregating up other data points, that paints a pretty clear picture of where we need to make investment. This gets even more interesting when you take it down to the subservice line level. So breaking out the cardiology on the last slide, and looking for variation in what we're capturing. This organization, just by reading the data without knowing who it is, looks like they're doing a great job in capturing some of the more tertiary cardiology services, with cardiac surgery being amongst the highest, cardiac cath, vascular, but kind of being a little deficient in medical cardiology, a little deficient in vascular, a little deficient in vascular cath. So again, you might just look at this and say, and also in diagnostic cath, there might be opportunities to evaluate each of those subspecialties for, do we lack access? Do we lack quality providers? Do we just not have enough supply? Are our cardiac surgeons very reliant on referrals from non-employed medical cardiologists, which maybe is a threat that a long-term competitive threat that we want to address through either a recruitment or alignment strategy? Lots of data in here that can be brought into the process to create an effective plan. Third, so while I want to talk about identifying supply and demand gaps and why this data is useful, since I spent the first couple of minutes of this talking about why we don't want to focus on just community need. So again, community need can be a useful data point when you're thinking about your medical staff development plan. We really like to emphasize it provides great context when combined with other data points to give us a feeling about recruitment need, but it should never be reduced down to, oh, our market is oversupplied by 2 medical cardiologists, so we can't recruit cardiology, or this market needs 13 primary care physicians. How many of those 13 should we recruit? that we would say is poor use of community need data, but it's great as context for evaluating a market when we're looking at other data points as well. So what might that look like? So from an adult primary care example perspective, so here we have the market that we looked at earlier, which was subdivided into regions. So taking the supply and demand data down to a regional level gives you a little more granular feel. This market was in particular a very urban market, also very undersupplied in primary care, especially compared to markets its size. So there's a lot of opportunity. And then one of the questions, especially from an adult primary care perspective, might be, well, how do you regionalize that data? Because looking at it even at a cluster level makes it a little hard. So how do you regionalize that even within clusters when you're talking about when you're talking about something like primary care, and maybe even then taking it down to the zip code level and kind of matching that against local demographics, local routes of travel. Gives you a feel for if we recognize that we have intense primary care need throughout our market, but what portion of that need do we want to address, and exactly where do we address it? Taking community need data and using it in that fashion gives it a lot more context than just looking at, oh, we need 30 primary care across our market. It's more, we have needs across our market, which are in some markets are more severe than others. And if we localize that, then that gives us a feel for perhaps where we should be allocating our recruitment resources. In terms of succession planning dynamics, not a whole lot to say on this other than it's more of a threat than it's ever been, and at least my time in this industry doing this type of work. We're frequently seeing a lot of organizations kind of with these same dynamics where 36% of medical specialties, 30% of primary care, 32% of surgical care, 42% of OBGYN. That's probably a bit of an extreme example, but are approaching age 65 or going to be 60 plus. Again, we're not seeing not seeing every provider retire at the age of 65. It is frequently the age where we say you want to have a plan in place. I know across markets, that's sometimes a more or less sensitive conversation depending on the dynamics of your medical staff and your culture. But it's always something we have to have our arms around, especially because for a lot of organizations that we've worked with in the past few years, I mean, just the succession planning lift in terms of recruitment, just replacing what we have. If we assume everyone's going to be out in say a 65 to 67-year-old time frame, just that lift would probably subsume all the resources that we might have in our current recruitment department. So it really causes us to ask some different questions about how are we going to deal with this? How are we going to execute a growth strategy as well as deal with the status quo? That takes us nicely into our next two sections, which are, we're going to start with the existing capacity of the health systems network and then go into the ideal mix of physicians and APPs. So one data point we frequently see left out of medical staff development planning is kind of bringing in the employed group kind of current and planned future state. And some organizations that's done really well, and some organizations that's very siloed from the process that also creates kind of provider recruitment activity. Quite honestly, again, the greater percentage of your medical staff that is employed or the number of specialties that are virtually closed, those organizations tend to do a better job of thinking about the dynamics of the employed group and medical staff development as a whole. But in some organizations, some large, very prominent organizations, that process is very disconnected. So we would advocate for, in a medical staff development process, really looking at the existing capacity within the health system's current network of practices and providers. Ideally, you would do that across the entire medical staff, a little more challenging with our independent providers. So that's why we focus on the employed group. We typically think, needs, when we start thinking about, do we need to recruit incrementally? The question we want to ask for every specialty, or make sure we're asking internally, is how can we better use existing resources before we go on to add additional resources? for all the very obvious reasons. These are very expensive decisions. These are very expensive resources. How do we maximize them? So in the medical staff development planning process, having measures of productivity, having time to third next available appointment, anything we utilize internally that gives us a feel for our existing capacity should kind of be layered against the data, because, again, all of these are individual data points that when put together tell a story. So we might see, that our market has a real need for, say, adult primary care, but if we're still ramping up 5 to 10 primary care providers who are all below the 25th percentile, it might question, well, do we still need more primary care providers? Do we need to do something to better ramp our patients that have needs not utilizing our primary care practices? Is it hard to get in? There's all those questions that need to be asked before we need to continually address the needs in our market. And so what that, and I guess one other point is, we run into a lot of organizations where very mature specialty groups that are killing it in their individual specialty and kind of have a monopoly over the health system service line, even within an employed group, all get up into that 75th plus percentile. They're all on their heavy work RVU contracts, and they don't want to recruit. And I'm sure everyone on this call probably has some form of that in their organization. That really is kind of the opposite of access, right? I want to be scheduled out 3 months because I like knowing that I'm going to be at the 90th percentile as long as I'm just executing my schedule. Through this process, when we start aggregating these data points together, being able to show, yes, not only do we have an orthopedic surgery need in our market, not only do we call for an expanded orthopedic service line strategy in our strategic plan, but all of our existing resources are 90th percentile and booked 3 months out, paints a more compelling picture than just, our market needs more orthopedic surgery, which sometimes is that data point alone is looked unfavorably upon by providers. So the data, what does that data look like? It sometimes looks like this, and breaking this down by specialty is even more helpful. But getting a feel for, how many of our providers are still ramping up, how many of our providers have been in practice for, if we look at maybe these being our providers that are ramping up, noted that they're 1 or 2 years out of joining us, what are all these other providers who have been out of practice or with us for 2+ months or 2+ years? Do we think that they're going to build a mature practice that's at the productivity level that we want them to be? Do we need to replace them? Do we need to reallocate them? Those are the types of questions that we should be asking through this process. I said I also want to talk about defining the ideal mix of physicians and advanced practice professionals. This is critical for a number of reasons. One being, we all know about the looming physician shortage. So as we're trying to evaluate how we address just our incremental growth strategy, this becomes critically important because we know that advanced practitioners are going to be a more present part of our existing medical staff, our existing practice model. But also when we go back to the succession planning dynamic discussion, as we're talking about, having to replace maybe on average 30% of our medical staff within the next 5 to 7 years, we are not going to be able to ramp up I would argue most organizations are not prepared to ramp up their recruitment strategies to meet that need, and the supply is not out there to meet that need. So it really requires us to think about our ideal mix of advanced practice professionals in this process. And we would advocate for, a lot of organizations still think of APP recruitment as an operational activity, worse an HR activity, rather than one that is proactively thought about and strategically planned for. So that might look like, well, our orthopod's getting close to 90th percentile. We're going to add an APP, and they're going to figure it out, and the APP can see some of the follow-up patients in the practice, and it'll be great. That is a very safe way of ramping up providers and advanced practitioners, but it also is very reactive. And so we would argue for being a little more proactive and recognizing that, not only does our APP recruitment strategy need to change, but probably our overall view of practice model and the dynamics within our practices needs to change, because APP recruitment and utilization is going to continue to be a major strategic driver of how we create access. And so, without going through all these in detail, I think pretty much every specialty has some capacity to utilize advanced practitioners well. Obviously, there are major variations, health system to health system, and the cultural tolerance for that, compensation model dynamics that might encourage or discourage APP utilization, practice model, practice care model transformation and adoption of those models varies heavily. But in every organization, there's the opportunity for, kind of proactively defining ideal ratios, which again is probably not something you're going to fully accomplish and get the medical staff to buy in on through a medical staff development planning process, but should be in the back of our mind as we're thinking about our medical staff development strategy over multiple planning periods as a health system leadership team. And so, evolving key specialties, away from, a lot of primary care networks right now are probably 3-to-1 or 4-to-1 position to an APP. Some definitely have some examples of maybe 1-to-1, but if we look 10 years out, or we probably want to be 1-to-2, 1-to-4, because that's just what it's going to take to meet demand with the supply dynamics that are going to exist. Behavioral health, orthopedics, cardiology, neurology, all specialties where we frequently, as we're building medical staff development plans, proactively think about, are at least these specialties effectively using APPs? And then they certainly can, APPs can certainly be applied to basically every specialty, as I said earlier. But thinking about what's right for the way that your practice is practiced, and having that built into the medical staff development plan, again, we think is critical, because APPs are going to be critical. And then finally, the last component of what we would recommend bringing into the planning process is just stakeholder observations and insights. There's a lot of detail that we usually bring into this process, but to summarize it on a slide, gathering your provider's opinions on where we're deficient, either from a quality perspective, from an access perspective, just from an overall need perspective. One, it usually mirrors what the data says, but occasionally it doesn't, and that provides a lot of opportunity to provide insight into a specialty that otherwise purely quantitative data points may not have suggested were an opportunity for growth. It's also, as I mentioned earlier, extremely useful from a compliance perspective, because we frequently, especially in more, if I could create a rural/competitive market, where sometimes community need dynamics get thrown way off. Maybe a smaller hospital has loyal groups, independent groups in a market supporting it, but since the community need dynamics are thrown off, and there's 2 hospitals in a market that maybe should be 1.5, you find that maybe the ability to support an independent practice is based upon community need is really thrown off. So we would recommend, gathering the qualitative input qualitative input that could be utilized when you're coming down to, making the decision to, say, do a net income guarantee for a supportive OBGYN group that the community needs study per se doesn't support, but provider need would indicate this is or provider opinion would indicate this is a massive need. Gives you some flexibility within reason. So if we have all those data points, and we're aggregating those together in a medical staff development planning process, again, the next step from our perspective is you have to get the right team at the table looking at this together. One, it's important to have the right perspectives around the table, but 2, the challenge we see for a lot of health systems is we frequently see them executing a bunch of different medical staff development plans put together by different executives, different portions of the organization. And what it ultimately results in, 1, a lot of inefficiency, 2, sometimes a lot of overlap, but 3, sometimes a lot of gaps. Because if we're not looking at everything comprehensively and we're only all kind of focused on our own silos, it sometimes misses the opportunity for what could we do if we were thinking about everything together. So bringing everybody together and having this discussion as a whole and building a plan together gives the organization a comprehensive view, again, of how we're tying our strategic plan development to our medical staff development and all the decisions that went into that. When you end up building, say, a 3-year plan that might look like this with allocations of specialists across and primary care across our market, with physicians and APPs both accounted for in the plan, this is the type of plan that might, again, give us direction for where we're going over the next 3 years. I'm sure everyone on the call would agree no health system has ever developed a 3-year plan that has been fully 100% implemented and never changed. But what this does give you is the ability to start allocating budgets, start allocating resources, to start proactively driving leadership action towards a goal of this is what we want to do. And over that 3-year period, we would recommend refresh this plan at least every year, maybe look at it every 6 months. But think about, challenge yourself with, okay, we're monitoring all these data inputs now. Has anything changed, and does our recruitment plan need to change? As well as how well are we doing against this, and how many opportunistic, unplanned recruitments did we end up making over this time frame? But what this gives is basically the direction to the organization of here's where we're going, or here's where we would ideally go based upon the data we've looked at as of today. And let's start executing this, and then let's make it a living plan, and let's keep working on it together going forward. So again, this is where we think medical staff development planning needs to be in today's environment. It's a broader team working on it. It's a much broader view than looking at community need, and it's incorporating not just what physicians do we need to recruit, but how do we evolve our overall deployment of our providers, physicians and APPs, and again, not just we need to bring them in and figure out what we need to do with them, but we need to have a proactive plan for how we're utilizing them to execute our strategy. So with that, I hope everybody found that helpful. At this point, I will say thank you. We'll move on to questions. If anybody has any questions, I'd be happy to take them.
Sure, there were a few that came through. The first one being, I think you were back on slide 27, but what were the typical data sources used to collate these data points?
On slide 27?
Yes.
For succession planning, that typically that you should be able to pull that together through your medical staff office. I would frankly be surprised if that was the question. But if it was, I hope that was a helpful answer.
Great. And the next question is, how do you factor in the element of practice and consumer indicated appointment access? I've seen situations where the models indicate a need for X number of particular specialty, but the practices show that new patients have virtually no wait time to get in.
Yeah, and I think that's a great way to come back to looking at why we want to incorporate access metrics from our employed network. So certainly, if we have the ability to access measures of productivity, time to third next available appointment, that really needs to be contrasted against the other data points we're aggregating, one of which might be that community supply number, supply and demand number. But for employed specialties, that's a relatively easy answer. We shouldn't be looking at community need in a vacuum. We should be looking at it in the context of multiple data points, one of which is our employed practices. From an independent practice, so the dynamics around independent practice get a little weirder, right? Because if it's a service line that is supportive of our health system, but is completely independent, meaning we don't employ any of those providers, and we really don't have any insight into the relative productivity or access of that practice other than what our business development office might tell us or what the community might anecdotally tell us, that gets a little harder. And so that's where we might back up and say, well, let's understand, utilizing outpatient and ambulatory claims data. Let's evaluate the dynamics of that specialty and see if patients truly are moving around that practice or that specialty and seeking care elsewhere. or if the anecdotal things we're hearing don't really sync up with the data. Um, and again, that would maybe if the specialty is completely independent. If it's one of those specialties where you have your employed group and there's an independent group in town that's maybe kind of collaborative, competitive. Um, that again, that gets a little more difficult. That really goes. I would argue, were I advising that health system, it really depends on what our strategy is for that service line, and if what we want is growth, and what we're not seeing out of our independent partners is the type of volumes that are generating our overall growth strategy for that service line. Then maybe the community need data is more important to me, because we clearly have needs and our independent partners aren't doing their part. That's certainly the most complicated dynamic of those three.
And there was another question on data sources. It's related to the marketing data points and demand, just where you get the sources for that.
So great question. From a community need standpoint, there's try not to give an oral history of how community need data came into being. As I mentioned during the webinar, we started doing this because we were required to from a compliance perspective, right? I mean, it may have been helpful in a pre-Stark environment, but at the same time, really, Stark really kind of laid out the guidelines for, if you are going to support recruitment to independent practice, you need to do a study of community need, and you need to be able to document that there is a deficit of X specialty in your market, so that you as a health system can distribute dollars to an independent practice to support their recruitment. Now, as we've moved, I guess continuing the oral history, Stark lays out a number of actuarial models that define physician to population ratios. Most of them are older, but they're the ones that are kind of canonized within Stark as these are the ones you should use. Those models, as they've gotten as they've gotten older, require updating for different changes in practice patterns of specialties, changes in just basically the standard of care for specialties, changing consumer demands for specialties. Those are all types of proprietary adjustments most of us that do this type of work make. It's quite transparently not consistent from consultant to consultant. So it's really all kind of on our thought process around how do we see the need, taking the existing population models, population of demand models, how do we see that these models have changed, and then how do we make them local? So one of the ways that we recommend doing that is bringing in local incidence of disease, local mortality data, in order to really adjust the relative utilization of certain specialties based upon kind of that publicly available data. So again, this data exists because it's required to, and because it does, as we've said, gives a good directional feel for supply versus demand. But for all the reasons I just said, it has its value, but it should not be used as a standalone data point for anything other than compliance-driven decisions. And if it is being used for compliance-driven decisions, it should be utilized in exactly the way the START guidelines lay out.
Thank you. And how often should a health system go through this level of process?
I think, if we go back to getting people around the table, aggregating all these data points together, I think anything more than 2 to 3 years is overkill. From let's build a comprehensive plan based upon this aggregation of data points. But I would, as I kind of wrapped up the presentation, reiterate that I think this is something where we test the validity of it every year, at least every year, if not, again, twice a year. If we've aggregated all these data points, we should be able to update all these data points. So what we should be seeing is success in addressing our gaps in supply versus demand, what we should see is increasing patient overall capture of patient share of care. What we should see is the capacity of our employed network kind of evening out, where we shouldn't have just 90th percentile providers in a specialty, but we also shouldn't have a bunch of under the median providers. So we should see all these data points trend in the right way if our medical staff development plan is being executed correctly over time. We may not, if you're just starting this, you may not see all those results in year one, but if you adopt this kind of philosophy and move through it year over year, we should see all of the data points we're bringing into this process improving in the direction that we want them to improve. But I would recommend at least updating this every year and kind of challenging your assumptions about how did, just looking at what's here on this page, how did these numbers get on the page, and are they still relevant for where we are a year from now? And if not, how do we need to proactively adjust? Because again, the last thing we want to do when it comes to provider recruitment or deployment is be reactive, because that gets very, very expensive. And it results in not just in expense, but in lost opportunity as well.
Thank you. And what are the benchmarks for patient share of care, and what should health systems shoot for in core service lines?
Ooh, that's a great question. Find that slide here. So when we're looking at patient share of care, I'll tell you, a lot of health systems. I mean, this is a relatively new space. Kind of brought upon us by the utilization of claims data. I say new as in the last 5 to 10 years, but it's really becoming more and more prevalent. I would say in the last 3 to 5. As we're able to kind of comprehensively evaluate not just inpatient but outpatient and ambulatory, across all CPTs, DRGs, ICD-10s, and aggregate them up into service lines. So we get asked this question a lot, and I would tell you it's the worst kind of answer. It's either a consultant's answer or an economist answer, which is it depends. But it really does depend on the dynamics of your market, because I'll tell you that these numbers vary heavily by the dynamics of your market, the level of competition in your market, the relatively closed versus openness of your medical staff in certain specialties. And so what we say to most organizations is we don't need to necessarily view this as a benchmark. So here where we're at basically 40% in cardiovascular, if we aggregate commercial and government together, that's neither good nor bad. What is bad is if that goes down. What is good is if that goes up. And if we're doing what we need to do from a strategic perspective, from a strategy perspective, from a provider recruitment and development perspective, from a business development perspective, that is a number that will go up. And so what we advocate using it more as an internal benchmark against ourselves, as opposed to I want to be benchmarked against 20 other like health systems in the country. Because even if a 400-bed regional center with exactly 280 employed physicians and exactly the same revenue, if I compared you to 10 other organizations like you, plus or minus 10%, I would suspect we would see wildly divergent patient share of care numbers by service line. But what I would say is what we need to do with that is one, compare it across our other specialties and look for gaps, but then two, have that kind of be the benchmark which we benchmark our own performance against going forward.
Thank you. And do you account for research and education within a clinical FTE?
Absolutely. I mean, as you're again, if you're going back to kind of that community need approach, and you're developing what FTEs exist and what FTEs do we need. Absolutely. Obviously that's going to vary a little bit, the dynamics of specialty, dynamics of exactly what those providers are doing, but they absolutely should be accounted for. Truthfully, academic medical centers are one of the more fun models to apply this type of approach to medical staff development plan to, because there's so many unique dynamics with those components.
Well, and the last question we have in queue is, how does the medical staff development planning process change or adapt for systems with overlapping medical staff?
Oh, you know what? That's a great question. So I think this type of process is actually, I mean, it's I think it's incredibly useful for basically any type of health system organization, but especially, let's go back to the sample market here. So obviously this is this is probably an urban area served by 2 hospitals, and then what I would guess to be, without knowing exactly what market this is, gets relatively rural really quick, just given the fact that there are 2 hospitals in this market, and nowhere else. If we thought about this as maybe a more urban market, with a lot of pockets of suburbia and maybe other health systems, within the market. And Louisville, where I am currently based, Louisville, Kentucky, is a great example. We have two health systems, hospitals, within the region. Well, actually 3 health systems with hospitals in the region. This type of process that not only contemplates the individual hospital's needs, but the health system, thinking of the health system as multiple hospitals competing together in a market against other competitors, is incredibly helpful. Because if we think about who we put around the table, then we're not just putting our hospital or solo health system, solo hospital health system leadership around the table. We're bringing together, hospital presidents, service line presidents that think health system and not hospital. And we can get some really great thoughts about, one, how do we attack, get the phrase, how do we attack a market as a team, and how do we most optimally deploy our combined medical staff as opposed to our individual medical staffs. And maybe to make that, take that down a level, I can think of a client that has six health systems within an urban region, and all of the hospitals individually executing, well, four of the 6 individually executing their own spine strategies, some with neuro, some with ortho, doing it because hospital presidents are incentivized on P&Ls, and not health system performance, which you could maybe argue is a compensation issue, not a medical staff development planning issue. But they're executing their own strategies and creating duplicate resources, causing internal cannibalization, because there's not that holistic health system plan that says, here's how we're moving resources around the market, here's where we're going to do certain procedures, here's the providers we need to bring in to serve the market, and we're going to figure out how they serve the hospitals. But what we're not going to do is all individually execute our strategies and hope that it all works out. Now, that's maybe a bit optimistic, especially for those of you who are kind of in that dynamic. But this is the type of process that really brings together all the data points to at least start that conversation. How do we build a system level, market level medical staff, and not just focus on our individual hospitals and P&L's needs?
Thank you. And there actually was one quick question. Can you elaborate on the proprietary adjustments to the physician to population ratios, or any recommendations?
Not in any great detail. I mean, each specialty has its own dynamics that have evolved since the various models have been developed. I mean, and I'm probably a little too focused on the historical physician to population models that Stark recommends, because there are a handful of newer ones. I mean, and even utilizing the current U.S. supply model, which looks not just at, it doesn't attempt to calculate what should a market have in terms of providers versus population, but just what is the existing supply, is a relatively good barometer for kind of what a market might aspire to be overall. So it's basically less aspirational and more, here's your market compared to all other markets, but maybe locally adjusted for what's going on in your market in terms of incidence of disease or mortality. Beyond that, it's basically the intellectual property of whoever's doing the adjustments.
Thank you. That concludes the Q&A, and I just wanted to thank you, Travis, and a special thanks to HSG Advisors for sponsoring today. Any closing comments before we wrap up?
No, I appreciate the opportunity and appreciate everybody's attention, and look forward to any feedback.
A copy of the recording will be shared with you all later today. Thanks so much.
Thank you.